Committee. On behalf of the Medical Center, on behalf of the Westchester Medical Center PPS, I welcome everybody to our meeting of the PAC, the first meeting of the PAC since we've become operational as a PPS on April 1st. So, to everybody for participating, thank you very much for helping us get to the point we are. Thank you for that we are about to begin. Today, you can see on your agenda, if we could, thank you. We're going to do, I'm going to start off with a couple of quick things. I want to welcome, then turn over to June and her team to talk about the Master Service Agreement and the timeline. We're going to talk about the implementation plan and the status of that, and the various lines that we have in terms of submission. Talk about how all of our partners can participate and what we're looking from all of you. And finally, just finish up with some Q&A. So we can to the next first page of the status update. I'd like to quickly tell everybody that we have gotten our project valuation. We were awarded a maximum achievable of about essentially $274 million. You can see on the slide both some of the details, but also this is actually the first page of the letter we received from Jason Helgerson. We have signed it, sent it back. They have signed it. This is now formally our award. $174 million, approximately $264 million is the project valuation, and we have about $10 million of bonuses that we can earn. We are still waiting guidance from the state on exactly how we earn the bonuses, but our expectation is that we will be in a good position to do that. Before I turn it over to June, I just want to say on behalf of the Medical Center, a tremendous thank you to the CRHI team for getting us to where we are today. We couldn't achieve the valuation we did, and this is a very good valuation. We're 10% higher than what we had hoped for, and what the numbers we've talked to you about in the past. I think the staff has done a tremendous job in pulling it together, getting us to this point, and very well positioned to go forward. So thank you to the CRA team, and thank you to all of our partners who've made this possible. I'll ask June to talk about the timeline going forward.
Wonderful. Thank you, Tony. Okay, well, some of the things we'll be talking about this morning. Here. Next slide, thank you. As you know, Domain 1 implementation plan was due June 1st. That plan, which Deborah will speak a little bit more about in a few minutes, was in fact submitted on Friday. So on Friday, we submitted the organizational sections of the implementation plan. What happens now is that goes to the independent assessor. The independent assessor provides us with feedback and an opportunity to mediate all of the things that they would like us to fix in our implementation plan. And then, so that comes back to us, that gets remediated, resubmitted, and at that point, we will make that available to everybody and make it public. In July 31st, all of the project plan implementation submissions are due, and that undergoes a similar process of assessment by the assessor, remediation, and resubmission. On around May 18th, we received our DI-1 payment, which is 60% of the first year, and you may or may not recall that our DSRIP payments are not equally distributed over the 5 years, but they actually are, they peak in year 3, and in the first year, I believe the total award was paid, what,
43 million.
43 million,
Yep.
Of which 25 million has been deposited in the bank, and the next 2 tranches will happen subject to our satisfactory performance of deliverables. The October submission will be the second quarter deliverables, and the December submission will be the quarter deliverable. Is that correct?
And then you want the year end.
And the year end will be March 31st. So our next 2 DSRIP payments will be in January, February, and in July. There are further DSRIP payments, as we understand it right now, until July of 2017. So just for all of you who think that this is all a lot of money, we have to make this money last cash flow basis until July of 2017. So that's a total of $43 million. Okay. I'm now going to turn over, now that you've received that kind of information, to Peg, who's going to talk about the status of the Master Services Agreement. Peg, would you like to bring us up?
Thanks, June. So I want to briefly go over the status of our interactions with our partners. But first, I wanted to thank everyone for their cooperation. I know it's a lot of work and looking through them, but we really appreciate all the effort everyone has made. Just briefly, we've been at this about 2.5 months now. You'll just see the time schedule quickly. We started March 13th. We sent out the draft. We had 2 webinars, excuse me, so that people could ask questions of us. We had attorneys as well. We were on the phone. So we wanted to provide as much information as possible. Excuse me, I'm losing my voice. On May 14th, we sent out over 250 MSAs to providers for their signatures. They asked that May 27th that we would get the signed MSAs returned to us and give an update. As of this morning, we're up to 64. Yay. So thank you, everybody. Many over the weekend, so we were happy. So we just ask if people could please get those to us. It really helps our whole process. And I wanted to say, and it really goes, Kier, to the next slide, if you could turn to. Many of the questions when people were submitting the MSAs were asking us, okay, when are you going to contract with us? What are the deliverables? How is this going to work? So here we wanted to give you a preview of the work that CHI is engaged in order to develop the programmatic costs category, the project schedules, and the work that needs to be done and have lined up before we actually go out and submit to providers. So things like our cost-cutting projects, infrastructure, patient-centered medical home, EHR, RIOs, all of those, many of those, some all of those to all our projects. So that's the work that we are involved in now. We're setting project quality committees. We will be setting up implementation groups. We'll be having an in-depth assessment with our providers of specific areas like IT, PCMH, workforce, again, to get information. And we're going to sample providers so when we go out with our projects and cost of them, we have more information about it.
May I just add this,
Sure.
June? Let me just add something to this, Peg. Many people have asked us, when are we going to be meeting with you in order to work on the schedules that will determine deliverables for each participant and the resources that will be required to execute those deliverables. And just so nobody gets panicky, the way that we have to do this for expediency's sake is we have to work first with those provider groups where we are heavily dependent on those providers for our early stage deliverables to the DOH. So we will because we can't negotiate with 250 organizations all at once. We will be starting with those organizations that come up earlier in the process of our having to meet deliverables to the state. So if you don't hear from us in the next few weeks or even in the next month or two, please do not panic. It doesn't mean that you will not hear from us. It just means that we have to begin to negotiate the Schedule Bs according to how each provider plays into the deliverables that the state is requiring of us. So if you have any further questions on that process, please feel free to speak with Jesse, Dr. Sullivan, or with Peg. But I just wanted to lay that out there for you guys.
Thank you, and I think that was an important point for everyone to get a sense of how we just need to literally roll this out and develop that. So I just wanted to end this. Again, these are steps that we are starting or going to be in the process of, and it's the summer, fall. I just wanted at the bottom make a pitch, or you probably would like to, for our PPS Quality Conference that's going to be in October. And we put down 3 dates to hold those dates, and soon we'll be able to the day and location.
Yeah, I'll remind people at the end and just say a little bit more about that.
Okay.
So thank you.
Super.
Okay, Deborah, would you take us through an example of the process that we underwent to complete the initial phase of the implementation plan?
Absolutely, and in fact, it does tie back to a lot of the project schedule steps that Peg just shared with you. Everything we're doing is documented within our implementation plan. Thank you. What was due today, and we did submit on Friday, were the organizational sections of the implementation plan, as well as the general project implementation overview and the first project, the integrated delivery system, because of how integral that is not only to the organizational sections, but to all of the other project plans that we're currently developing. The plans themselves for the remaining projects, including diabetes, asthma, patient engagement, are due July 31st. Each section goes through a remediation period with the independent assessor, which means what we've submitted was due today. We will get feedback on within the next 30 days, and we'll be given 30 days to address any comments from the assessor. Once sections are finalized, of course, we will be happy to share them as we have in the past our other submissions with our PAC, and we'll post on our website. Understand this is a little bit of a process yet. What we submit Friday in each of the sections really are our responsibility as a performing provider system to satisfy milestones and requirements that the state expects of us. I circled 3 of those related specifically to governance because I thought I would just quickly walk you through and give you a sense of what the template looks like and what the steps are as we develop them. So for the next slide, for the government structure update, milestone, finalized governance structure and subcommittee structures, you'll see that the state gives some definition of what that is over on the right, governance and committee structures signed off by PPS boards. And there's some to the quarterly reports. Obviously, we're putting steps out there, and the independent assessor each quarter will ask us, have we achieved a step, and where are we with subsequent steps? We have already identified our standing committees, and we have transitioned our executive committee that worked with us on our project planning through last December to an operational executive committee. And so you can note that I've indicated check off, just as the assessor might. We've already established our Hudson Region DSRIP partnership with other PPSs in the region, the Hudson Region DSRIP. This actually here should be not the clinical committee, but the public health. And we actually have steps, as Peg just shared, to establish our clinical committee with the FIP. We'll head of a schedule and appointing members on the various committees that report to the executive committee. The assessor would expect for our first quarterly report due July 31st is our tick-off of the steps that we committed to in the first quarter, as well as some indication of how we're faring with the second quarter. So if you look at the next slide, for example, I would be giving some information to the assessor on where we are with respect to establishing the project-oriented work groups of the PPS Quality Committee, and so on. And so we can go through these next couple of slides, and probably any one given section, given the milestones, is usually about 11 of these, what would be the equivalent of 11 of these slides. These were submitted. We await the assessor's feedback, and we will undergo the remediation period. Currently, we are working on our project plans, and I know Jesse can share a little bit more about those with you.
Thanks, Deborah.
Great. Thank you, Deborah. Thank you, June. Care if you could go to the next slide and the next. There we go. So So as you know, we have 11 projects, and there's a listing of our 11 projects. You've all seen those before. As has been previously said, the project plans are due to the state July 31st, but we can't wait until after that to begin to work on these projects. So while we're completing project plans, we will also be beginning work on the projects. And if you'll go to the slide, one of the first things that we need to do is that for 8 of the 11 projects, the requirement that we provide to the state of what this is defined as an activated patient relative to that project. And this table lists the state's definition of what constitutes an activated patient for the particular project. And then to the right, you'll see call by date with the numbers that we have committed to for each of these projects. So, for example, for the Health Home at Risk project, we've committed to having 500 patients with a care plan by the end of June, which is 4 weeks away. 4 weeks away, right.
Yep.
So, you know what? Except that I think that's a mistake. It should be September. Yeah. Maybe I just can't read the slide. Maybe
No, it says 6/20.
Yeah,
6/20. It should be 9.
It should be 9. Thank you. Okay. Still plenty soon enough. And so you'll see for each of these, so we'll fix the slide before we post it. We'll fix the dates on the slide. But the numbers are right. The dates are wrong, but the numbers are right.
The next date is correct, though.
Yeah, right. It's just the 6s should all be 9s on there. But we want to just have people take a look at the specific requirements for each of these projects and realize that when June said earlier that we sort of have to begin making arrangements with partners around those who can help us meet our deliverables, and this is the sort of earliest deliverable that we really have to start talking. And of these 8 projects, 7 of them, deliverable is going to come mostly from primary care, and of those, for 4 of them, it's almost exclusively from primary care. So we're going to be focusing actually on conversations with primary care practices, not exclusively, but very heavily. And what we're going to be asking you is how can you help us to identify the patients who've received these services, and if this is not a service that you're presently doing, how can we help you to begin to deliver this service? So this is going to be the focus of the meetings that we begin to have early on. Next slide. So this talks about a little bit of the detail of the clinical governance, and for most of the projects, for 9 of the 11 projects, we'll have a project advisory quality committee. Medical village is not on this list because each medical village is located in a specific location, and it will have an advisory committee. Can someone move the mouse? The village will have probably 2 project advisory committees, and the integrated delivery system is sort of everything.
Right, infrastructure, everything.
Right. But for these committees, we will have a specific advisory committee, and each of those committees will be looking at the requirements that came from the state, which are considerable. So the projects are considerably already defined to quite a degree. But there will be some room for the committees to think how we want to particularly address things, and particularly things that we want to address in addition to what is required. So I think we want to remember that, just going back to how we were talking about DSRIP way last summer, June pointed out this when I walked in, that this is my 1-year anniversary. So we've actually been working on this for a year. And one of the things we kept saying a year ago, all summer when we were meeting with people, is that is that the DSRIP project has lots of requirements that are set and fixed. But in some cases, those project requirements are very, very meaningful. And in some cases, they're a little bit more process and maybe not the most important thing that we can do in terms of improving, really doing the transformative things about making healthcare more effective, more efficient, and more patient-centered. And so there is some room within these projects and between the projects and sort of outside of the projects to think of the things that we think are really more important and cross-cutting than the specific deliverables. But initially, we have to focus on the deliverables, or else we can't have the resources that we could do the broader thing. So while initially we're quite focused on the deliverables, I want to reiterate our commitment to having that broader view as well. But appreciate if people give us a little slack in understanding that we're focused on what we have to do initially right this period. So each of these committees is going to come up with a bunch of things that have to be done. And most of those things that have to be done mostly have to do with things that primary care doctors have to do. Not entirely, but a whole lot of the things that have to be done have to do with primary care doctors. So here, if you could take us to the next slide. This is a high-level picture, without some of the detail, but a high-level picture of the governance of the PPS. And I don't know if I'm too far from the screen, and the print I have is too little for me to read. Thank you.
That one? Yeah, really.
I didn't anticipate. Great. So you can see at the very top we have CMS, and then New York State, and then there's the Westchester Medical Center, and under that in orange, our PAC Advisory Committee. And to the left are the regional, it says Regional Clinical Council here, but that's really a placeholder for there are 3 different coordinating committees, one for behavioral health, one for the public entities that coordinate with local governments, and one for other clinical care that we're going to coordinate through the population health improvement plans that are linked to the state of Rio. On the right, of course, is this for regional healthcare innovation, which is the project management office that is going to be doing the project support for all of this. There are, as you can see, 6 of the PAC Executive Committee, and to talk particularly about the Quality Committee. And the Quality Committee that supports the exec is actually called the Quality Steering Committee, and then those project advisory committees that I discussed on the previous slide actually report to that Quality Steering Committee. But on that previous slide, I listed all those different things that each committee would come up and how a lot of those would be tasks for primary care, and very, very mindful that it will not work to have requirements for primary care for any entity that come willingly directed to a primary care practice or a part of any kind that are not in a coordinated way. We can't have 11 different committees creating tasks at different time frames. We have to coordinate all of the tasks based on the implementation sites. And so we know that there are going to be 4 basic kinds of implementation sites. For medical village, there's going to be geographically local, so to Bon Secours in Port Jervis and to Health Alliance in Kingston. Those are specifically geographically located projects. Then for behavioral health crisis particularly, that really involves deliver behavioral health care for the most part, and those are going to have, and that's we're going to have to think of everything that pertains to those facilities. Far to the right, there's a number of projects, particularly the community engagement project and engagement, that are focused mostly in community-based organizations, and so we're going to coordinate the things that we're asking people to do that are based in the community. And the box in the middle is really where the bulk of the projects are going to be implemented, and largely in primary care. Primary care communicating with hospitals, primary care, communicating with health homes, primary care, communicating with behavioral health, but largely primary care based. And so I just want to say, so when we talk in the next slide, as we're going to, about how people can participating in these local deployment groups that closely relate to the kind of organization that you are, is where you really want to be. This is where the action is going to be. Next slide.
Should we also just highlight that the local deployment groups will be sort of geographically based and could have elements of each of these 4 boxes in them? Yeah. So I think we quite explained that graphically in our slides, but each local deployment council has functionality from each of these 4 boxes. I just wanted to make that clear. And we split it out so that you could see in terms of the project management office who the lead would be for the specific areas. But we envisioned 4 or maybe 5 local deployment councils that we would be comprised of individuals that will have competency or that would be stakeholders for the 3 boxes on the right. Okay, I just wanted to make that little clarification, if that's a correct word.
Yeah, that was good.
Indicate the geographic reach.
Yeah. Right, okay, and I know that a lot of people
kind
have
of hard
questions.
to do that here.
It's hard to graphically represent all of this, as you can all appreciate. So anyway, I just wanted to offer that as some clarification.
Great. So if you could take us to the next slide. So what are the opportunities to participate at this point in time? So we've asked in the past for what is your passion, and many of you have told us area you're particularly interested in, and we have, if you've already communicated us, we have you on a list. And for the next month in June, we will be convening each of the project quality committees that I talked about. And if you already expressed an interest in a particular project committee, you will receive a notification of that a meeting when it's going to happen. But we're still open to hearing from more people who are interested in a particular project.
Right.
Yeah.
Yes.
So this is Deb, and I just wanted to share that we've already had a couple of meetings of the Hudson Region DSRIP Public Health Council. We have representation across CBS and LGUs and all 3 PPSs, Montefiore Medical Center, Refuah Health Center, and Westchester Medical Center. And we've been working on a number of initiatives related to tobacco cessation, medicine and education, working across sectors. We have a school-based project. We will have one geared to college campus. We have a communication effort out to providers regarding reimbursement and benefit for tobacco cessation under Medicaid, as well as to the patient side of our community, saying, you know, ask your doctor, you're covered for this. We have subject matter experts. We have folks, of course, from American Lung, as well as some nice research underway for evidence-based practice regarding tobacco cessation. And we are putting together information for specialized populations, such as those with behavioral health issues or those with intellectual and developmental disabilities. We have about a membership about 30 strong, and our meetings generally collect 12 to 15 of us. So I'm happy to spread that word just, you know, once again. If we've missed one or you're interested in what we've been doing, we're happy to share our meeting minutes and agenda, and we also have a private group on the mix.
A little bit more about the mix.
Oh, so what I think I share enthusiasm about the mix, and it's been working really well for our Public Health Council because it's a forum that allows us to collect and amass all of the information that we gather as we're working on these various initiatives and have them available at all times for anyone who's participating to be able to go in and say, you know, CHI just put out a research report on BH and tobacco cessation and asthma. I need a copy of that. And because we know how challenging it is for any of us to navigate through our own emails. And so all of our communication takes place through the mix, we can post comments. We had gotten it from Montefiore post some of her training videos on how to walk a patient through a tobacco cessation or to use motivational interviewing. We can post our agenda and our meeting minutes. So it's a great place to collect our comments and all of our information. And as each of the groups and advisory quality committees are formed, it's a thought that may consider setting up your own group, private group on the mix, and I can connect folks up, or Jesse and the various teams, Peg and the various teams. And as you come into our groups, we can get you hooked in. So in general, you might like to get your own login now, because there are so many other groups that are open across all PPSs and across New York State. All information about DSRIP and all of the updates are posted on there are webinars with Jason Helson, so it's a great spot to get to do one-stop shopping, if you'll allow me, on DSRIP.
Peg, you about BH, and then I have a couple of things.
Yes, and I also wanted to mention the work that we're doing with the other two PPSs, Montefiore and Refuah. And we have a committee that we're talking about behavioral health, particularly on the behavioral health crisis services, because our goal is to work together and come up with similar protocols, reporting, how we stand up services in certain communities where there's some big gaps. So I just want to chime in, that's another group with the three PPSs working together so that we can be efficient and really stand up things as we need to do.
So the last two things I wanted to was the importance of local deployment, and particularly primary care. So in addition to convening the project-specific advisory committees over the next month, we are going to begin to have some local primary care focused meetings. We've had some meetings with individual groups, but I think I'm going to try and maybe do some meetings that could be to more than one office in a particular location, to go into a little more detail about what we need initially from primary care practices and what kind of resources we could provide to support that. And then the final is I want to talk about our quality conference in October, and ask you to hold the dates the 14th, 15th, or 6th, and we were very quickly on one of those dates. We thought we had, but the hotel we were looking at might not have the rooms we need, and so we'll have a fun date lately. And we did look very carefully. We could find no conflicting holidays with any of those three dates. So I hope that'll be good, but I'd ask you to hold them in your calendar. And our idea is that this would be an all-day conference for participants. I feel, and my colleagues here feel, that part of really transferring things sometimes really depends on relationships, and that it's really important to have some face-to-face meetings and not just do everything on the web. But geographically, that's very, very difficult. And so we've said in the charters, as we've started to draft charters for some of the committees, that they'll have a face-to-face meeting at least once a year. And we thought one way to accommodate that is to set aside a day so that we can have a bunch of different committees meet. We can share best practices among ourselves. We can also bring in some outside speakers for some best practices relative to the kind of things we're going to be doing in DSRIP from around the country. So we anticipate, at this point, I can't quite say who the speakers are going to be, but we're talking about some really exciting people to come in. But it would also be a chance to do some of the training that we're required to do. So we will, I know for sure that we will, for example, have a session on getting a mix and what is there and how to use it and how to see it. Deborah talked about some other things that are training that's required for the DSRIP project, but also that I think people find useful. So I just ask people to maybe right now pencil in all three of those days, and we will quickly get back to you next week. Yeah. So yeah, we just have a little hotel thing to work out. Okay. Yeah. Let's see. That's sort of what I have. And next slide. So you go to the next slide, right. So this is our contact. So we've sort of highlighted in blue that the primary contacts for our partners are Marcy Colon, project manager, and Melissa Thomas Belmar, who's a physician liaison, and they have divided up the counties so that sort of have a single point of contact, so we can kind of coordinate internally, so that we don't have someone contacting one person and we're not talking to each other. We're trying to make sure that we're really well organized and having things go through the account reps so that we keep track of things. So those people are your primary contacts to reach us, and then through them they can easily reach out to us. Doesn't mean you can't contact us directly. You can see all of our information there, but we think that the data goes through the.
And we've asked by a number of groups. Most recently, Orange County mental health providers asked me this, so we wanted to get out more phone numbers, email address, as we are fortunate enough to add staff, but also to have a full sense of who we are and who to contact if you have a specific issue that if Melissa says call Joe, you will know that Joe does our finance. So you get more names and more familiar with who we are.
I should just point out, this is June, that we will be posting this webinar to our website a little later today. So all of the slides and the contact information that you're seeing will be available through CRHI-NY.org later on today. So I think that that completes our formal agenda. I would just like to reiterate what Tony said in appreciation of all of our partners and all of the hard work that everybody has put in thus far. I would also like to acknowledge the CRHI team. There was a tremendous amount of time and energy and effort that's gone in over the past year to get us to this point, but there is no opportunity for rest. DSRIP began April 1st. Our first quarterly report is, our first quarter ends June 30th. First report goes in July 31st. So far, I think we're pretty much on track for the first. We're good on the first quarter deliverables.
We're good.
So thank you all again, and thank you for your upcoming participation and support. So Jesse, yeah, and that's leading me into the next topic, which is here. We are open for questions. So would you like to let us have any questions so far, Kier?
Yeah, of course. And just a reminder for folks on the phone and also online, if you have a question, you can submit it through the bottom right-hand chat function on your screen. Again, there's on the bottom right-hand side of your screen, there's a chat function, and you can submit your question to the host, Kier Wallace. When you already answered the most popular question about whether the slides will be available after today's meeting, we'll only received one other question so far, and that's whether any types or categories of organizations might be contacted first with respect to next steps or schedules associated with the Master Services Agreement.
Yeah, I think that if you're a major primary care provider in our network and you have a lot of attribution, for the WMC PPS, you can expect to be contacted first. Then everybody else will be contacted sort of as soon as we get through the top deliverables. But everybody will be contacted, and that's about as much information as I can give you right now. So next question.
Those are all the questions we've received.
Okay. Well, I would urge that those of you that have additional questions, perhaps you could email to the CRHI contact that you think is the person closest to your question's heart, and we will promise to get back to you as soon as possible. And again, thank you very much for your time today, and to be continued. I hope everybody has a wonderful week. Stay dry, and we will be in touch soon. Thank you all very much.